start now?
Yes, sir.
I think we have a sizable number now. This morning, we are going to be looking at the importance of regular antenatal clinic and this type of classes that we have. And then we will also look at the importance of the vital signs and the investigations that we do when we're pregnant to come to the hospital. I'm going to speak for about maybe 20, 25 minutes, and I will allow us, or maybe 30 minutes, then allow us to have as many questions as possible. While we start, I'm going to mute us so that you will not interrupt me. Can you hear me, please?
I can hear you, sir.
Okay, yes, I mute us so that after I've finished, then you can unmute yourself, and then we continue the discussion when you're asking questions. I'm going to start by telling us the importance of regular antenatal care and plus some of these, why we have these classes. As we know that pregnancy is not a disease. It's more or less a physiological condition, but can actually be complicated, can have some complications that may be deleterious and life-threatening, and sometimes very fatal for both the mother and the babies. And that is why it is necessary for us to have this type of classes and have regular antenatal attendance so that some of these problems can be looked into, detected, treated, or prevented, as it were. And therefore, there is a need for regular antenatal care. And the WHO recommend that a woman who is pregnant will actually have contact with the doctor before the first 3 months of pregnancy, so that some of these threats could be detected and taken care of. And from then on, have at least 8 regular attendance to the clinic or to the provider throughout the course of that pregnancy. The first visit should be before the 3 months, preferably, but latest 3 months, and thereafter have regular attendance 8 times. If you attend less than 3 times, then you are considered not to have received antenatal care. And these clinics are very essential to prevent, as I said, complications that may arise in the course of the pregnancy that may be life-threatening to both the mother and the babies, or each of them, as the case may be. Therefore, when we come to the clinic, the doctor routinely will go through some of this procedure. The doctor will ask us questions, and that is what we call history taking. You want to ask questions about the present pregnancy, about your past medical condition and pregnancies, family history, anything that could be dangerous, inherited, or acquired that may have happened in the course of one's life. We notice that many of our women have not actually had regular contact with doctors or regular treatment or examination before the antenatal. Therefore, it is very, very essential in our environment that we use this opportunity, the time of pregnancy, to assess medical care. And when the doctor takes the history, the doctor is going to conduct what we call a physical examination. And this one will comprise of the general examination to look at the general well-being of the woman, whether or not she's pale, take the vital signs, which I'm going to discuss later, and specifically you want to examine pertaining to the pregnancy. Depending on the age of the pregnancy, the doctors know what to look for. And from there, you conduct some investigations, which we are going to look at also later. And from this history, examination, and investigations, doctor will have a good, or the provider, it doesn't have to be a doctor, could be a midwife, could be traditional birth attendants that have been trained. It should be somebody who has been trained, you know, to put those informations together and arrive at, you know, a conclusion that will be helpful to both the mother and the baby. And then there may be treatment offered or referral to a higher center or to a better place where adequate and professional care can be given if the particular clinic does not have the required, you know, wherewithal to take care of that pregnancy, especially the first pregnancy, pregnancies that have had surgery before, pregnancies that are difficult to attain, pregnancies in elderly people, pregnancies that may have other things complicating it, you know, like hypertension, diabetes, or what we call high-risk pregnancy. You may need a referral to other centers where you can be adequately catered for. And generally, if you do this regularly, you will notice that complications are prevented, or their results or consequences are ameliorated. They are reduced, as it were, if it's not completely preventable. Two, there will be a better fetal-maternal outcome. You know, you now have, you know, survival of both the mother and the baby, and the quality of life is improved, and the quality of the babies that are born and their future, you know, generation is secured. Because many of the problems we have in childbirth and after childbirth, especially in the life of the children, arise as a result of the pregnancy, the delivery, or what happens after delivery. Then there will be better outcome for both the baby and the mother. There is safety and everybody is happy. And therefore, it is very, very essential that these regular clinics are conducted and attended to. And of course, classes like we are having here, you will agree with me, is very, very beneficial, and they are very beneficial for us so that we have information. Information is power. And now it is information that rules the world. If you don't have information, you will not be able to take rational decisions. If you don't have information, you will not be able to help you or help other people. If you don't have information, you find out you are living in the dark. It is information that brings knowledge. And if you use information wisely, if you use knowledge wisely, I mean, in an appropriate way, then you are called wise. If you want to be wise, you don't want to be foolish in this world, you must acquire relevant information, and you must interpret them well, and you must use them for your own benefit. Even the Holy Book says in Hosea chapter 4, verse 6, it says, my people perish for lack of knowledge. Many people die. Many people lose their life. Many people are maimed. Many people are killed. Many people are destroyed. Destinies are wasted because of lack of information. It is this information we are providing. It is this that we make available by having this type of classes and by conducting regular and very, very useful antenatal care. Therefore, thank you very much. I know that questions will arise, but we should not only avail ourselves of this, you know, important, you know, vehicle of survival for us and for our family and for our children. If you're going to have 2 children, 3 children, why don't you have quality ones instead of having 10 that are, you know, destroy their brains and cause damage to them in life? Therefore, it is good to use this information for our benefit. Those are the benefits and the importance of regular clinic attendance and, of course, classes like this. Briefly, I want us to go to the importance of the vital signs and the investigations when we come to the clinic. If you look at the name, vital signs, they are vital because they are very, very important. They are vital because they are, sometimes so important that they can mark the difference between life and death. They are important. They are necessary. They are very, very vital. And they may be divided into some of these physical things and some that we may need some gadget, to take care. Let me tell us something. As you come to the clinic, you register. So one of the things that they will do as you come in is to ask you to weigh you, what we call the weight of a woman. Everybody has a weight from a child to the old age. And there are weights that are good for you and weights that are dangerous. And therefore, we want to look at your weight. Are you underweight? Are you overweight? Do you have excessive weight, what we call obesity? And there are ways of calculating that. And this one guide the doctors in taking some national decision. Therefore, your weight is one of them. Secondly, we want to measure the height. How tall are you? Are you very short? Are you of average size, height? Are you tall? This is used to calculate, and with the weight is used to calculate what we call basal metabolic index. That one will be able to tell to guide us to know whether or not you're actually underweight, whether your weight is normal, whether you are overweight, or whether you are obese. BMI.
Have you cleared that room?
Basal metabolic index. Hello? Therefore, we use our weight in kilogram and the height in meters to calculate what we call BMI. And that's why we guide us to know whether you are overweight, underweight, normal weight, or you are obese, which has a lot of implication health-wise. Thirdly, pertaining to height also, our height has a relationship with the size of the pelvis. If a woman is very short, it's likely that the pelvis will be small. If you now have a big husband and your baby is big, then it will be difficult for you to deliver. Therefore, height has relationship with the size of your pelvis. Therefore, our height is very, very important. Number 3, we want to check the blood pressure. The blood pressure is so important because it will determine whether or not adequate blood will even flow to your baby. Is your blood pressure low? Is it normal? Or do you have hypertension? If there is hypertension, there are complications. Because pregnancy itself is a stress. And sometimes pregnancy, there is what we call pregnancy-induced hypertension or pregnancy-associated hypertension. If there is hypertension before you get pregnant, we would like to know, because it could be worse during some time or sometimes during the pregnancy. And there are some other complications that can come. If you have hypertension, is there any protein in your urine? And is there edema and things like that, what we call preeclampsia, and they can go to eclampsia. Therefore, it is important to know the blood pressure. We want to know your pulse. The pulse rate is the number of times the heart beats in a minute. We want to know the rate. We want to know the regularity, because it will tell us the state of your heart. Is the heart under stress? Is the heart normal? Are the rates regular? Are they irregular? If they are irregular, how irregular are they? And then you want to know the rate. Is it very fast? Is it very slow? Is it normal? You want to know the respiratory rate, because the respiration, the lungs, determine the way oxygen will get to your baby. The oxygen exchange takes place in the lungs between the air and the mother's blood, and this is carried to the baby through the placenta. Therefore, if you are not breathing well, there may be impediment to that oxygen delivery to the baby. Want to know the respiratory rate, want to know if you are able to breathe freely or not. There asthma, is there anything that is making you to have difficulty in breathing? We need to know that to determine your oxygen carrying capacity or the amount of oxygen that the blood is carrying. Also, we want to know the temperature. Do you have fever? By the time the temperature on the mother, on the surface of the body of a mother is about 37, 38, say 38, that woman will have fever. The inner temperature, what we call the core temperature, will be higher than that. And you can imagine somebody who has just gotten pregnant and the baby is very, very tiny, and you have a temperature of 39, 40 degrees. That one alone can even kill the baby. It's like they put you in an oven yourself. How long can you actually survive oven where they bake bread? And therefore, we need to know the temperature and what to handle so that we can take action if it's high. Also, nowadays we have what we call monitor that we can use to monitor the oxygen carrying capacity of the blood, the saturation, oxygen saturation capacity of the blood, what we call we use what we call the pulse oximeter, we call it PO2. We use pulse oximeter to determine the oxygen saturation. Normally, it should be between 97, 98, it should be 97, 98, or even 100%, 96 and above. If it's getting below 95 or low, so sometimes like that, you are telling you that something is disturbing the oxygen carrying capacity of your blood. And that one can affect the baby also. Therefore, you need to know the PO2. Then also, when you come like that, we want to know the state of your urine. Therefore, as you come to the clinic, we want to do what we call urine analysis for protein, for glucose, or for other things like ketone. If there's glucose in your urine, we want to know if it's just, by chance, or if there's diabetics, what we call the blood sugar disease. If there's protein, if there's glucose, we want to know if it's diabetes, is it related to pregnancy? Is it something that's, been there before? Or is it because we have what we call low renal thresholds in pregnancy? That one will guide us whether or not to go and do further tests, especially blood glucose level. Then if the urine contains protein, we want to know if it's just that there is infection, or it's just by chance, or if there is hypertension that is already affecting the kidney. If there is ketone, where is it from? Is it because the person had diabetes, or because the person has starved, or because the person is dehydrated? Therefore, all these points are very important as you come in. And that's why every time you come to the clinic, before you see the doctor, we do these vital signs. They are necessary. And we will want you to make sure you avail yourself of them before you even go to. Sometimes people come, you say, give us urine, go and do this, go and do this. They say, no, I can't pass urine now. I just pass urine. We want you to do them because they guide us in taking decisions. You want to do blood pressure. Some people will wear some clothes that they will say, okay, take the blood pressure over my clothes. That one is not going to be accurate. The doctor you must expose your arm, and this curve must fit properly. It must be done properly. Or else, if you give us the wrong information, the doctor or the attending, officer, we have a wrong conclusion. Therefore, all these are very, very essential. And we appreciate if you make sure that you cooperate with the relevant staff as you come to the clinic to do them. That's about the vital signs. Lastly, the third thing we have to do with the investigation. Why do we conduct all the investigation that we conduct? Is it just not important enough for you to just come in and see the doctor and go away without running all these tests? The answer is no. They are important, and I will try to explain to us one by one some of the things we do. The investigation ranges from the blood test, the urine test, the ultrasound, and some things to exclude infection, even to exclude cancer, abnormal growth during pregnancy. Now, the first one that comes to mind is what we call a full blood count. When they take your blood and we do a full blood count, we want to check the hemoglobin count, the amount of hemoglobin. Is the hemoglobin that carries the oxygen in the body, hemoglobin. That's what carries oxygen to the body. The oxygen binds to hemoglobin and is taken around the body where the body utilizes it. It's the corollary of that is what we call the packed cell volume. The packed cell volume will measure the percentage of the red blood cells. For hemoglobin, we measure the amount of hemoglobin in that red blood cells. And they're important to help us to assess how oxygen is getting to your body. If they are low, that's what we call anemia. And if they are low, it means the body cannot carry enough oxygen to the body. Your body cannot, the blood cannot carry enough oxygen to the body.
Where is the remote?
And in that case,
as the two emeralds go head to head.
I may have to meet us again. I think some people are coming, some comments are coming now. Please, let's finish before we start to comment. Now, if the blood is not carrying enough oxygen, that is going to cause a lot of problem because it is from the oxygen you have in your blood as a mother that the baby is extracting its own. You can imagine if you don't have enough, how would the baby get? Therefore, that's important that you have enough hemoglobin, packed cell volume. And then you want to check the white blood cells and they are differential. These ones are the things that you use. These are the cells, the agents that fight infection in your body. If they are very high, it could mean that there is infection. If they are low, it could mean that you may not be able to find infection. Or depending on the differential, on the type that they are lymphocyte, neutrophil, polymorphs, and things like that, which the doctor will interpret. But these are important as you are coming in for us to know the state of your blood. Then you want to do a blood group. And there are two types of blood group. There's what we call the ABO group, and there's the rhesus blood group. The ABO group, some of us, when you ask, you say you have A, some people will B, some people will say AB, some people will say O, depending on the antigen or lack of antigen that you have in the blood. I don't think we need to go into that. But just know that some people are A, some people are B, some people are AB, some people are O. And then you have the rhesus group. This is what we call the minor blood group. But it's a major one also. There are some minor ones. But this rhesus one, we will just tell you whether it's rhesus positive or rhesus negative. It's very important because if you are rhesus negative and your husband is rhesus positive, your baby may be rhesus positive. And that baby's positivity will stimulate the mother to produce antibodies, something that will be fighting the baby's blood. That's why we need to know so that your blood will not be fighting your baby's blood. Those who have rhesus negative, who are rhesus negative, know what we are talking about. They need to take special injection. We need to check antibodies in their system. And then when they deliver, we need to give them injection to prevent the baby's blood from stimulating them against future pregnancies. Because sometimes the blood of the baby and mother do cross. They do cross over to each other. And that blood can stimulate the mother to go and produce antibodies against the baby. Of course, the ABO mainly is to make sure that we don't give you wrong blood if you need transfusion because of very transfusion reactions. That could be dangerous and even deadly. Also, we need to do genotype. In our environment here, we have sickle cell, we have hemoglobin S, we have hemoglobin C, and some people have some minor variants. But usually, majority of people have hemoglobin A, some minority of up to, sometimes 1.5. Okay, I don't know the percentage of sickle cell, but many of us are AS. And if you have AS and AS, they can give back to SS. And up to 1.5% may have, especially in some tribes in Nigeria, they have C. Some tribes don't have C, but tribes, especially the Yorubas, they have C. Some of them have, they have hemoglobin C. It is not as bad as hemoglobin S, but we need to be careful. When you're pregnant, you can have the problem that hemoglobin SS can have also. Therefore, we have A, we have C, S, we have C. Those are the three major ones to contend with. And doctors must know, because they each have their advantages and disadvantages, especially S and C. Especially when they combine and you have SS, or you have SC, or you have CC. If it's AS or AC, the A will more or less neutralize the effect of S or C. But if it's SC or SS, we need to, to take care of those people, especially. Of course, we will do HIV. These days of infection, HIV 1 and 2, because we know this is a viral infection that can cross from the mother to the baby. The same thing with hepatitis B virus. It's a viral infection that can affect the liver. And of course, it can affect the baby. It can be passed from the mother to the baby. Hepatitis C also is the same thing. It can cause some problem for the baby, and it can cause for the mother. And therefore, we need to know HIV, hepatitis B, hepatitis C. There are some occasionally when we need to go further and do what we call touches syndrome, when we know that there are problems, and that is toxoplasmosis, toxoplasmosis, herpes, simplex, syphilis, and things like that. But mainly we will do HIV, hepatitis B, and hepatitis C. Also, in the form of those viruses, we have rubella virus. Rubella virus. What we measure is rubella antibodies. And this one can cause what we call German measles. It's a mild form of measles. But if a pregnant woman has it, especially early in pregnancy, it can cause deafness or blindness in the baby. It can even result in abortion. Therefore, it is good to check the mothers for it. Rubella antibodies. Also, you want to make sure that the woman doesn't have syphilis, and therefore we do what we call VDRL test or regene test. This is for syphilis. Syphilis is a bacterial infection, and it is, dangerous for both the mother and the baby. It can cause a lot of severe deformity and problem especially for the baby. Therefore, we need to check it, VDRL. Now, there are sometimes some special ones that you can, some tests we do. If there are family history of abnormality, or if the maternal age is increasing, then you can afford, we advise that you take what we call prenatal screening, prenatal genetic screening. And this one, you want to diagnose if there is an abnormality in the baby before they are born. Because the higher the maternal age, the more likelihood of abnormality. Abnormality can occur at any age, get me right. Abnormality in the baby can occur at any age, but it is commoner if the mother and even the father also, if they are getting old. Therefore, we usually advise after about 35 years of age and more, we advise that you take what we call prenatal diagnosis to check what we call Down syndrome, to check neural tube defect and other genetic anomalies. And usually this one is done before the 3 months or before 17 weeks. You can take the mother's blood, or you take a sample of the what we call chorionic villus. We do a chorionic villus sampling, and they will go and study it. They do the genetic studies, and they'll be able to tell us whether or not there's abnormality. These babies, These are very expensive. These tests are very expensive, but they are worth doing. And of course, nowadays, if the mother is AS and the father is AS and the husband is AS, then it is advisable that you do CVS also to diagnose whether or not the baby that you want to born is sickle cell, to prevent some of those terrible consequences that can occur after birth. Also, as I said earlier, many of our women are coming to see doctor specialists for the first time, and they have never checked what we call cancer of the cervix, pap smear. That one can be done when you are pregnant. It's not a routine test in this country, but it is something that is advisable. You do a pap smear, to check, to make sure there is no cancer of the cervix. Also, during pregnancy, especially when you are getting to around 36, 37 weeks, it is advisable that you have a swab from the cervix to exclude what we call infection due to beta streptococcus that can cause, eye problem and other infection for the baby during birth. Beta streptococcus. That one can be done around 37 weeks of pregnancy. Those are the routine tests that we do. Of course, we should not forget, I've mentioned to us that we do urine tests. When we're talking about vital signs, urine test is very, very important. Every time you come, you do urinalysis for glucose, for protein, for ketone, and we culture urine for infection if necessary. Also, you want to exclude diabetes, because if you have done urine test, we want to make sure that there is no diabetes. Therefore, between the 24th week to 32 weeks of pregnancy, we want you to do what we call oral glucose tolerance test. Oral glucose tolerance test. They give you 75 grams of glucose they do the fasting blood sugar, give you 75 grams of glucose to drink, and then they take your blood 2 hours later. And we found out that one will exclude diabetes if it's normal. The second aspect of the test that we do, apart from all those taking sample, is ultrasound. Ultrasound scan has become the eye and the hand of obstetricians and gynecologists nowadays. They are so important that we can hardly do without them. And we thank God for science. Ultrasound, the first trimester, we usually recommend 3 ultrasounds if there's no complication. The first trimester will tell us the number of babies that are there, the age of the baby. We tell you whether or not there are other masses, other things in the womb that can affect the baby, like fibroids. Many of our women have fibroids. Then we want to check if there is fibroid. In second trimester, which is the anomaly scan, we check the parts of the baby. The parts of the baby are fully formed, like the heart. Look at the heart, look at the lung, look at the liver, look at the kidney, you look at the stomach, the bladder. You want to see the legs, the limbs of the baby, the face of the baby. All those things can be seen in the second trimester. And of course, the third one in the third trimester will tell you the position of the baby, the placenta, and adequacy of the liquor, and all sorts of things to prepare you for delivery. If there is any need, then you can do other tests, but other scans. But these 3 ones, this one I just mentioned, are very, very essential. And these are the ones that we recommend. When you need other ones, the doctor will let you know that these scans are necessary, and we do it appropriately. Now, I've been able to talk to us about the importance of regular antenatal clinics and the classes that we conduct, the importance of our vital signs, and the investigation that we conduct when you come to the clinic. I would now want us to ask our questions. I think I've spoken for about 33 minutes now. Started 4 minutes after. This is 11:37. Therefore, in the last 23 minutes that is remaining, I want us to have our discussion. Therefore, you can now unmute and let the question keep on coming. I hope you can hear me now. Okay, please. Yes, let the question keep on coming now.
body of the.
Hello, please identify yourself and then you speak clearly, please.
They don't have this kitchen. This place.
Okay, somebody has asked, you say, what is the relevance of platelet count? What is the relevance of platelet count? Thank you, ma. Now, platelets are part of the, what we call full blood counts. Full blood counts. And they are part of what is produced when red blood cells is being formed in the bone marrow. They are for blood clotting. Blood clotting. Therefore, we want them to be adequate so that the blood can clot if there is injury, if there is surgery. If you have low blood platelet count, the blood may not clot. Therefore, it is important there must be adequate platelet. That is one. Two, platelet count also indicate that the bone marrow is active because it is the bone marrow that produces the red blood cells and the platelets. Therefore, if you don't have enough platelets, it means that the blood marrow may be defective. Therefore, it is very important. It is part of the full blood count. Thank you. Any other question? Yes, please. Any other question?
Hello. Hi.
Hello.
Good morning, sir.
Good morning, ma'am.
Good morning, sir. So
Yes.
I want to ask about this fundal growth and what week do we start measuring that? Because I'm at 30 weeks now as at my last appointment and that has not started for me.
Fundal what?
Fundal growth or fundal height. Like
Fundal
when you
height.
measure the
Okay,
belly and
fundal
all
height.
that.
Okay.
Yeah.
What it is when the doctor examines you that we talk about. Then you know I told you when we examine, it could be general examination like pallor, blood pressure, heart rate, heartbeat, and things like that. All specific things pertaining to pregnancy. And there are parameters we look for when we examine a pregnant woman. One, we want to know the size of what we call that's what you call fundal height. We want to know the size or how far the pregnancy has gone, the size or the age of the pregnancy. Yes, the age of the pregnancy. And that one will be determined by the size of your tummy, the size of your womb. You know, the baby is in the womb. Therefore,
yes,
usually for the first 3 months, we cannot even feel your womb in your abdomen. But after that, you begin to feel it and it begins to rise up in your abdomen to your navel, and then after the navel, above the navel. It is that womb that we measure that we say is the womb, the upper part of the womb is what we call the fundus. And that is what we measure to the lower part of your abdomen. From the upper part of the womb to the lower part of the abdomen is what we call fundal height. We call it symphysis because there is a bone in the lower part of your abdomen called symphysis pubis. And therefore, we call it symphysis fundal height. From the upper part of your womb to the bone in the lower part of the abdomen. Now, if the womb is at the level of the umbilicus, that is what we call the pregnancy is about 20 weeks or 20 to 22 weeks. And then we begin to measure from there, that place, upwards or downwards. If you say you are 30 weeks, then the doctor will be able to tell you that it's 5 finger breadths above the navel, or if he uses tape, he is going to measure 30 centimeters. That is the symphysis fundal height. It tells us how the baby is growing. If you assuming you are 30 weeks now, and they now measure and say, see, it's 24 weeks, they will start to question. Is it that you are not sure of your date? or is it that something has happened to the baby? That's it. But if you are 30 weeks and the doctor measure and it's 36 weeks, he will now be wondering, is it that you are not sure of that date, or there are more than one babies, or there are other masses in the womb that make it to be bigger than the usual thing? That one guides us to be able to determine the weight, the size, and the rate of growth of the baby. Thank you.
Thank you, sir.
Welcome. Any other question, please?
Hello. Hello, good morning, sir.
Morning, ma'am.
Okay. You said something about the ultrasound at second trimester. Yes. That normally they try to find out any abnormality and all that.
Yes.
God forbid, let's say the scan shows, I don't know, any abnormality. What can be done at that time during the pregnancy?
Well, if a doctor suspects abnormality,
yes,
the doctor may ask you to repeat the test so that he is sure what he's doing, or he will tell another person to check again to be sure. Now, if they still confirm the same thing, then they will let you know. They are going to let you know, and they are going to tell you the solution that may be available.
Okay.
That one we want you will know what to expect and how to prepare. I think it's very, very important.
Okay.
Yes, there are times we do ultrasound and we notice that maybe the kidney has problem or the stomach has problem. We tell the mother and the father, this is what we have seen. When the baby is born, it may not be 100% like that. And then, but these are the things that can be done. If the hospital doesn't have facility for that, then he may be able to refer you to where they can take care of that baby. That is one. In centers where they have been able to intervene, people have even done operation for babies that are yet to be born. I'm sure you sometimes last year or the year before, in Nigeria, even carried out operation on a baby and returned the baby back to the womb in America. Therefore, it depends, it's because of our, it depends on the type of facility that they have in each hospital. They'll be able to counsel you. If that hospital cannot handle that thing, you are referred to the teaching hospital where they may be able to take care of that. Where there may be some specialists that can take care of that baby immediately the baby is born.
Okay.
Okay.
But sir, sorry, is those ultrasound, are they 100%? As in, what I mean, if it detects any abnormality, is it always 100% that okay? If the baby come out, that's what it will be.
Of course no. Of course no. There's no human endeavor that is 100% correct. Okay. There may be observer error. The person who did it, who does the ultrasound, may not know how to interpret what he is saying. He may make mistake. Human beings make mistake. You know that sometimes what you think you see is not what is actually there. Therefore, there can be mistake. There can be human error. Even the machine also can have error.
Okay.
It depends on the sophistication of the machine. Some of the machines that they use in this country are the ones that are produced, how many years ago. New development, recent ones have come out that, will be clearer than what they are using. Therefore, if they tell you that it's like this, that's why I say you may have to go and check again to make sure that it's not a mistake. Even myself, I remember when we first started to do scan, and I was in the teaching hospital. They even told me I was going to have a baby boy, and I had a girl. Therefore, it happens.
Okay.
There may be some error. And that's why you need to, you get the advice and check again and check again.
Thank you very much, sir.
You're welcome. Hello? We still have some minutes.
Sir, there are questions on the chat.
I cannot see the chat. I cannot see your chat at all. Okay.
Okay,
I'm sorry.
one question.
Please, can you just tell me, because pardon, I can't see it.
Okay, one question says, what's the earliest time one can start experiencing Braxton Hicks?
For Braxton Hicks contraction, from around 30 weeks, around 30, 32 weeks, you start to experience it. Braxton Hicks contraction means the womb is just preparing for labor. Actually, uterus is never silent. It's never completely silent throughout the time of pregnancy. But you start to feel this contraction around 30, 32 weeks. Hello?
Okay, another question says.
Yes. Yes, somebody's raising hand there. Is it Tope?
It's a mistake. I think we've answered. Okay, so is it okay for the platelets to increase in pregnancy?
Oh, yes, because there are hormonal changes, there are too many things. It can increase, but there's a level that is normal. Anything above 150 to 250, 350, they are normal.
Okay, and then some people are asking why their fundal height hasn't been measured.
We measure every time they come to clinic, the doctor measures it. That's why we touch, when we palpate it, when we touch the abdomen, that's what we are doing. It's not every time it's not everybody that use tape. I've told you, you can use your fingers to estimate, and you can use tape. People, the pregnant women, we usually, that's why we say, when you expose your tummy, the doctors will measure it. That's what we feel in the form we feel. Or if you have if you are putting it in computer, that's what we put. Fundal height is this. Usually there are 5 things we look at. You want to look at the height of the funda, what you call the funda height. You want to see the lie of the baby. That is the relationship between the baby's spine and the mother's spine. If they are in the same direction, you say it's longitudinal. If they cross, you say it's either oblique or transverse. Then you want to see the presentation, which is the part of the fetus that occupies the lower segment of the uterus. If it's the head, you say it's cephalic. If it's the leg, you say it's breech. If it is the shoulder, you say it's shoulder presentation. That's the presentation. Then you want to look at the position of the baby. All these things we do, we may not take times, 10 minutes, 20 minutes doing it, but we do it. It is the position that will tell us where the back of the baby is. And we usually listen to the fetal heart through the back. Babies are coiled, they are flexed, and therefore you cannot get the chest of the baby to listen to the heartbeat. It is usually the back. That is where we put those things that will be, sound and power. We call sonicate or Doppler. That is it. That is the position that is telling us. That's where the back of the baby is. That is where the back of the head, the occiput is. The position will tell us the relationship of the baby's occiput to the segment of the maternal pelvis. And of course, we want to look at the descent, which is the 15th. The descent will tell us whether or not the head is engaged. That's why as you are getting to term and it's getting to go to labor, we ask you, is it, the head is not engaged, or is it engaged? Those are the things doctors do. They do it as you come. You may not know because we won't tell you one by one, but doctors do it. Yes, a question just came in now talking about pelvimetry. Oh yes, that's one of the that's one of the examinations that we do. And usually pelvimetry, there are 2 types or 3 types now. We have clinical pelvimetry where we use our hand, to estimate, to try to, to estimate, to determine whether the passenger can pass through the passage. The baby is the passenger. The pelvis of the mother is the passage. I want to see whether the passage is big enough for the passenger to go through. And there are things that we can do that usually when the baby has reached optimum size, and that's around 36 weeks. 36 weeks of pregnancy to 37 weeks, the baby will assume that the growth of the baby will not be too big, too much again. Therefore, you want to do the perimetry at that time, 36, 37 weeks. But also, if you do that and you are not satisfactory, you can go and do ultrasound perimetry nowadays. They do ultrasound. In the, in some center, you can still do X-ray perimetry to check the size of the bony pelvis to compare it to the head of the baby. Those are the three things, but it's usually done around 36, 37 weeks. Any other question, please?
Good morning, sir.
Good morning, ma'am.
Please, is there any particular problem that can lead to low lipo in pregnancy without any having discharge for the mother?
Oh, yes. The lipo actually, especially from around the middle of pregnancy, is mostly coming from the baby's urine.
Okay.
The lipo comes from the baby's urine. Mostly, there are secretions from the placenta, from the membranes. But most of the time, the lipo comes from the baby. And when the baby passes urine, the baby swallows it again and passes urine and swallows. But that lipo is changed from time to time. Nearly every 1-2 hours, you change it because fluid is coming from the mother. The lipo is being absorbed, and you are passing it out in your urine because the mother, apart from giving the food to the baby, my mother also takes the impurities from the baby through your own urine, through your, you pass it out like your own. Therefore, if the lipo is low, then you want to check the baby very well. Is the baby producing urine? Therefore, you want to check the kidneys of the baby. If the baby is not making urine, the lipo will be low. If the baby makes urine and that urine is not coming out, the bladder will be distended. And there may be what we call urethral valve, especially posterior urethral valve, that can block the baby from passing urine. In that case, the lipo volume may be low. Those are the things to look at. And then if the baby is abnormal, assuming the baby has chromosomal, have other abnormalities, that makes the baby to be small generally, and that baby is not well, that baby is abnormal, of course, the lipo volume will be low, especially those who have chromosomal abnormality. If the mother has hypertension that is affecting the baby, assuming the baby has what we call intrauterine growth retardation, it may be due to abnormality in the baby or abnormality in the mother. The baby will not make adequate urine. That lipo volume will be low. Therefore, the doctor will have to determine, try to find out as much as possible why is the lipo volume low.
Sorry, sir. In that case, if the problem has already arrived, is there any solution that maybe after the lipo has gone, maybe there is any solution to make it back?
Yeah, that's right. If they know the reason for the low lipo is determined, then the doctor will let you know the solution.
Okay.
Just like the other woman asked, if we detect abnormality, what do we do? Then we counsel you and provide solution. We let you know where those things can be addressed. We let you know what are the solutions.
Okay, thank you.
Now, there are two questions are coming. One is that when do we determine the position of the placenta?
The question.
Now, two questions. Position of the placenta. When do you say there's placenta previa?
Is it possible to feel like
the placenta?
Like pregnancy.
The placenta is detected by the ultrasound from around the 11-12 weeks upwards. But early in pregnancy, sometimes the placenta can be low, can be in the lower segment. But as the uterus grows, as the uterus becomes bigger, the placenta is pulled up also. And that's what we call placenta migration. Therefore, placenta previa per se is not definitely diagnosed or conclusively diagnosed until around 34 weeks of pregnancy. We can tell you it's low-lying placenta Even around 28 weeks, 30 weeks, we still say yes, it may still move. But by around 34 weeks, if the placenta has not moved, it's not likely to move again. If around 34 weeks, yes, we will say there's placenta previa, whatever stage it may be. Secondly, somebody asked about, what is that now? The infection that I talked about, talking about infection. And I said, you can check streptococcus. If there's beta hemolytic streptococcus around 37 weeks, just before delivery, so that you can treat before the baby will pass through the passage. 36, 37 weeks is appropriate. Okay? I think our time is fast spent. We just have 2 minutes more. We can have a question more before we call it a day. Hello? Hello?
Hello, good morning, sir.
Good morning, ma'am.
My name is Mrs. Adeshina. I just want to say thank you for talking to us this morning, sir.
Matron, thank you for putting Igbo in my pocket.
We really enjoyed it. Thank you so much, sir. Look forward to hearing from you some other time in the future.
Okay, well, thank you very much. Can we call it a day then?
Yes.
Now let's have a great weekend. God bless you.
Thank you, sir.
Thank you, sir.
Thank you. Bye.
Thank you.
Thank you very much, sir.